It's good to be here to talk about better care everywhere in this program series. I'm Dr. Chris Hayes, and my topic today is reconsidering opioids. A little about my background. I work at the John Hunter Hospital. I find it a privilege to be in the public system and have that less complexity that might come from patients paying for services. I work as part of Hunter Integrated Pain Service. We have quite a track record of looking at the interface between specialist practice and primary care as it relates to opioid strategy and broader approaches to pain. Our Brain Man series is one offering of interest into the space, and particularly the video Brain Man Stops His Opioids that's available on our website. In terms of professional organisations, I'm currently a board member of Pain Australia. I'm a past Dean of the Faculty of Pain Medicine and have been involved with the Pain Management Network of New South Wales Agency for Clinical Innovation over a number of years. From my early days as a pain specialist, I've always been interested in a broader and expansive approach to pain management, as is reflected in the biopsychosocial model. One does recognise, though, that there is the risk of that narrowing down to a predominantly biological focus if one pays a dominant emphasis to the first part of that, the bio. And the Faculty of Pain Medicine and other organisations have suggested the slightly long phrase socio-psycho-biomedical as a way to get away from that biological or biomedical dominance. From our team's perspective at Hunter Integrated Pain Service, we have in consumer-friendly language talked about a whole person approach as illustrated by the 5 fingers on screen there. And you can see that opioid strategy is one component part under biomedical, but there are other parts that I would argue are more evidence-based in the treatment of chronic pain and have a greater chance to bring long-term pain reduction and perhaps resolution. The clinician going broad is one thing, but there may be in some situations a reluctance on the patient's part to change behaviour. So hence this slide is part of what really motivates me in day-to-day practice. The diagram on the left is from Susan Michi, who's a behaviour change expert in the UK. The behaviour change wheel, as it's called, with the central green circle illustrating the patient's capability, opportunity and motivation. This recognises, though, that even if the patient is not motivated or has limited capability and opportunity, that there are things that can still be done, as represented by the red middle circle that talks about what the clinician can do, and the outer grey policy circle that talks about what can happen in terms of legislation, regulation and so forth. So there are multiple words there in that middle circle. From our team's perspective, what we as clinicians often end up doing is applying a mix of empathy and boundaries. If one applies tension to both poles, both ends of the rope in the tightrope analogy, one uses empathy, which draws the patient in, and therapeutic boundaries which may alienate them, but in using those two things together, it brings tension to the rope and allows the person to progress as the tightrope walker. All relevant to the context of opioid deprescribing and what are the alternatives available. So enough about me and my areas of interest. As we go through today's talk, I'm going to run through the scientific evidence base just briefly, really just a quick glance at some key studies from 2018. Then I'm going to talk about how this translates into practice in the Australian sector, and then look at the policy and regulation space as that is implemented at the moment across Australia. And then finally, just some recommendations, whether you be in the primary care or hospital settings. So as we look at evidence, it's worthwhile asking the question of what happens if we get this right on one hand, what happens if we get it wrong on the other hand, and there are certainly examples around the world, particularly in the United States, I think, of what happens when we get this wrong and opioids are overused. We have a lesser degree of problem in Australia, but certainly we are not problem-free. I would argue that if we are not able to implement current evidence satisfactorily, this leads to an increased burden of illness for our patients. It leads to over-medicalisation and ineffective treatment. It distracts people from the treatments that really work if one focuses on opioids in the treatment of chronic non-cancer pain. 3 studies from 2018 I want to touch on. The first is the most recent systematic review and meta-analysis by Bussey et al. From 2018, as I mentioned. They looked at 42 high quality, as they classified them, randomised controlled trials, noting, however, that only 9% of those were non-industry funded. So one wonders how high quality some of these were and whether there was potential for biasing these studies in the direction of a positive response. You can see, however, the forest plot. Apologies for the small figures there, but you'll be able to see from the plot that there was, when you average the results of these 42 studies, a shift to the left, meaning a representation of opioids having a positive treatment effect. However, it was only a very small treatment effect. If you average all that out, it was less than 1 point on the 0 to 10 scale. In fact, 0.69 centimetres was the amount of shift on a 10 centimetre scale. So this was statistically just significant, but we would say that that is not a clinically significant benefit in day-to-day practice. There was no difference noted in this study, interestingly, between the different categorical types of pain: nociceptive pain, neuropathic pain, or nociplastic pain. It has been argued previously that neuropathic pain is particularly resistant to treatment with opioids, but that is not something that comes up in the literature. In fact, neuropathic pain responds just as well, or depending on your perspective, just as poorly as any other types of chronic. To move to the study, it's known as the SPACE trial. This was from the United States. Again, 2018, Erin Krebs and colleagues took a pragmatic randomised controlled trial, meaning that it wasn't blinded. And in Veterans Affairs patients, they found 240 opioid-naive people who had either back pain or pain associated with osteoarthritis of the hip or the knee. And they randomised them in a non-blinded way to receive either opioid or non-opioid medications in primary care for 12 months. The mean pain intensity at the beginning of the trial was 5.4 out of 10 in both arms. What they found, interestingly, was that in the opioid group, that pain scores were consistently worse than the non-opioid group at all time points over the year. Also, they found that adverse effects were worse in the opioid group. Pain interference was no different. The study, again, 2018, McPherson and colleagues from the United States again, and Veterans Affairs patients. They took 550 people who had been on long-term opioid therapy for chronic non-cancer pain, and they discontinued them. You can see the types of pain as they classified them there, mostly musculoskeletal pain, smaller percentage of headaches and neuropathic pain. What they found with discontinuation is essentially it didn't make any significant difference to their pain. The median pain intensity before discontinuation, 4.8 out of 10, and post-continuation just marginally lower at 4.6 out of 10. The graph here subclassifies those patients into those with severe pain in the open circles, scores around 8 out of 10, moderate pain, the triangles, scores about 6 out of 10, and mild pain in the closed circle scores about 4 out of 10. And they tracked each of those subgroups over time, and you can see essentially what they concluded, that pain either did not change or reduced slightly as people discontinued long-term opioid therapy. I think this slide very much addresses a common fear of patients when opioid deprescribing is suggested, that they might go back to previous levels of intolerable pain. This study clearly suggests otherwise. How does this translate into clinical practice in Australia? The evidence essentially says that opioids don't work for chronic non-cancer pain, and one would recognise a degree of harm as well. How are we doing in terms of translation? I would say that variability is the key problem here. The evidence that we have available is that there is a fairly large variation in clinical practice that is unrelated to the patients themselves and more related to the prescriber and their beliefs and habits of practice and prescription. The Australian Commission on Safety and Quality in Healthcare has done a substantial amount of work in this area, and their Atlas on Healthcare Variation, which has been repeated a number of times, has looked particularly at variation in opioid prescriptions dispensed per 100,000 people across different postcode areas in Australia. And this is a map from the first Atlas that shows in the darker blue areas of high opioid prescription, and then in the softer colours areas of lower opioid prescription. So one can consider what leads to the areas of high prescription. Perhaps it's the low socioeconomic status of those areas. A lot of those areas are rural and remote. There may be lack of access to alternative services being a factor as well. The Commission on Safety and Quality in Healthcare, as I mentioned, have done work looking at opioid prescription over a number of years, and you can see that in the period from when they were starting to measure back in 2013-14 through to 2016-17, that there has been about a 5% increase in the number of opioid prescriptions per 100,000 people per year. Between these last two study periods, 2015 and 16 and 16-17, there seems to have been a levelling off. It will be fascinating to track that over time. Really, given the scientific evidence being as it is, we would like to see a clear downturn in opioid prescriptions, given that most of these are for chronic non-cancer pain. In addition to the dispensing increasing by that 5% over the study period here, there has also been an increase in the clinical variation between areas of high and low dispensing. So that's gone up from 4.8 to 5.1 fold over the study period. In 2016-17, the last period studied, 1.5% of our Australian population was on an opioid on any given day, and that amounted to 3.1 million people who had one or more opioid prescriptions dispensed in that year, and that was most commonly oxycodone. To take another study, because that opioid atlas has looked more at the primary care setting. This study I've chosen just because it gives us a little insight into what happens in the hospital setting, and one can argue about the respective responsibilities of primary care versus the hospital system in creating the overuse of the opioid problem that we have at the moment. This study from 2019 looked at opioid dispensing in a DVA population, opioid naive, admitted to hospital for surgery in 2014-15. There were 24,000 of those people, and it followed them for 12 months afterwards. So 15%, just over, were discharged on opioids, and then as these people were followed, of those 15%, 3,907 people, a subgroup, relatively small but substantial when you look at the size of the overall cohort. 3.9% of those discharged on opioids became long-term users, defined as those using opioids for greater than 90 days. So as I sit back and analyse this, we look at a combined contribution from the hospital setting and primary care in contributing to opioid prescription in the Australian setting, and I think there is a responsibility in both of those sectors for us to begin to do something differently. Looking at harms, this is part of how opioids translate into clinical practice. Death being the worst harm, we can see that there has been a rise in deaths over the years. As you look on this graph plotted from 2008 to 2016, these are opioid-induced deaths, and the unbroken line at the top of the graph includes all opioid-induced deaths, as opposed to the broken line, accidental, and the dotted line further down, intentional overdose deaths. If you look at the figures in the last couple of years, opioid deaths account for about 3 people per day across Australia, which is very similar to the death rate from the road traffic accidents cause. Mostly looking at these opioid deaths, they are unintentional overdoses, as you can see from the graph, and middle-aged males on pharmaceutical opioids, often with other pharmaceutical substances such as benzodiazepines, are at greatest risk. So before we move on to policy, the bottom lines: opioids are not effective for chronic non-cancer pain. There is a substantial risk of harm, and there is a substantial variation in the way opioids are prescribed by different doctors across Australia. Government are concerned about this, and so hence there have been recent changes in policy across the country. From an advocacy perspective, Pain Australia are playing an important role here in taking the voice forward from consumers and clinicians to government via an evidence-based filter. So important pieces of work in 2019 were the Cost of Pain report, a piece of work done by Deloitte Access Economics, sponsored by Pain Australia, and also the National Strategic Action Plan. So the Cost of Pain report showed 3.24 million Australians in 2018 with chronic non-cancer pain, and 2/3 of that group were of working age. So there are certainly substantial economic implications of this. The annual cost was $73 billion per annum, and there was a call in that report to support general practice education, providing more resources also to general practice, and an emphasis on multidisciplinary care. The National Strategic Action Plan is a call to government to support all of those aspects. Thinking beyond advocacy into our complex policy and regulation sphere in Australia, we have a number of groups involved in this. The Medicare Benefits Schedule obviously determine item numbers and the availability of alternate treatments beyond the pharmacological. We have the Pharmaceutical Benefits Scheme looking at medication subsidy, and as GP prescribers you will be aware of the authority requirements that have changed there. The Therapeutic Goods Administration are responsible for determining drug indications, perhaps their most important role, also product information, consumer medicine information, and recommendations to pharmaceutical company sponsors. I'll talk about their change in the indications for opioid therapy in a minute. Fourthly, there's the role of the state health departments that regulate authorities for opioid prescription in cases of opioid dependency or addiction. There's a further role under the state jurisdictions to bring in real-time opioid monitoring that's available at the moment in Tasmania, Victoria and the ACT, coming though to other states shortly. Therapeutic Goods Administration earlier in this year changed the indication for opioid therapy to say this, that opioids are no longer indicated for chronic non-cancer pain other than in exceptional circumstances. Interestingly, they haven't defined exceptional circumstances, which means that the onus is on the prescriber, if questioned, to be able to say, why is your patient representative of an exceptional case? Looking at the evidence which leads on to what are the policy indications for opioid prescription, it's very much accepted that acute pain, cancer pain, palliative care and treatment of opioid dependency are mainstream indications for opioid prescription. Government will not question your prescribing practices in those areas. Very much different to chronic non-cancer pain. So to conclude this talk, I just wanted to focus on some recommendations for the hospital sector firstly, and then primary care. So in the hospital sector, for those of us who work there, I think this is very much about addressing patient expectations wherever we get the opportunity to, which may be in a pre-admission clinic, during the admission phase itself, and then most importantly at discharge, that we create the expectation that opioids are an evidence-based treatment for short-term pain. However, they will be weaned and ceased, and we're not initiating them with the expectation that they would be used in the long term. Another important point from the hospital system at point of discharge is that dosage should be individualised according to what the patient has used in the previous hours. I think in the hospital system we've been often very much guilty of giving patients a standard pack of 20 endone tablets, for example, when they have used no opioids at all in the last 24 hours. We need to, if we're prescribing any opioids at discharge, need to make sure that that's appropriate in the context of patients' use over the preceding hours. Third point here emphasises, I mentioned, this is short-term use and that there is a clear plan to cease, and that this plan is communicated both with the GP and the patient. Otherwise we do set up this situation where perhaps a vulnerable patient goes to the GP and says, these opioids are very helpful, thank you, can I stay on them for a long time? We don't want to place the GP in that situation. What can we do in primary care? Firstly, do not use opioids for chronic non-cancer pain, I think, is a good rule, recognising the TGA's statement that there may be exceptional circumstances where you may choose to do this, but as we look at the scientific evidence, it is very hard to discern what that exceptional case might be. I would suggest, and this is advice very much in the National Prescribing Pain Service, the National Prescribing Service's recommendations, to have a conversation about opioid weaning anytime you meet someone with chronic non-cancer pain on opioids. Thirdly, it is very reasonable to have some shared decision-making with the patient and negotiation in this, but the issue is to negotiate when the reduction might start and the speed of reduction, not negotiations about whether or not to reduce. Fourthly, in terms of the practicalities, I would say that a standard reduction may be a monthly step down in dose, and you might come down each notch by about 10 to 25% of the starting dose. The fact that this is a standard plan means that you would be free to negotiate some non-standard version if you wish. Clearly there are contexts where you may want to reduce much faster than this. Equally, there are some situations perhaps where patients are very fearful, where you might come down a little more slowly. And finally, if during the reduction it emerges that opioid dependence or substance use disorder is the dominant problem, then you can always switch to a drug and alcohol program and get the patient referred for consideration of opioid agonist therapy in that context. In that situation, there's much more of an emphasis on opioid maintenance for a time rather than the steady push towards opioid reduction that is part and parcel of pain management. So thank you for listening. I will be available in the next segment for questions and answers before we move on to the further talks in the series. Thank you for listening.